Here is your question. Right, so if you've read and understood, kindly considering its surgical pathology station, kindly tell me what are the differential diagnoses that you will consider for this patient?
I'd consider acute osteomyelitis.
Okay.
I'd consider septic arthritis, gouty arthritis, hemarthrosis, and
Considering osteomyelitis, can you tell me what are the common organisms contributing to this condition?
there are some gram-positive organisms such as Staphylococcus aureus, Coagulus negative Staph aureus, Staphylococcus epidermidis, and some gram-negative organisms such as Enterobacteriaceae, E. coli, Salmonella, Haemophilus, Neisseria, and atypical organisms such as fungal infection, Mycoplasma, Mycobacterium.
Can you please tell me what is the pathogenesis behind this osteomyelitis?
In case of acute, the pathogenesis of acute osteomyelitis is it starts with microbial invasion, which can occur either from either hematogenous route or through direct contiguous spread from infections such as cellulitis or direct penetrating trauma during iatrogenic trauma or joint replacement. There is microbial invasion, which results in a stage of acute inflammation, which causes vascular congestion, fluid exudation, and polymorphonucleoside infiltration. All of these will result in the raised intraosseous pressure, which will cause intense pain and blood flow obstruction. Ultimately, on the second day, there is going to be a stage of suppuration where there is going to be pus formation within the medulla and the Bachmann's canals. And these pus will either seep backwards into the adjacent bony structures or to the joint spaces and along the Bachmann's canal and elevate the periosteum, resulting in a subperiosteal abscess. This will continue, and because of the obstruction of the blood flow and the periosteal abscess and the microbial
approximately yes, thank you, very good. Can you please tell me approximately all this cycle takes how long?
About 2 to 3 weeks.
All right,
time.
good. Can you please tell me what are the mechanisms or what are the methods by which these microorganisms infect the bone?
It can occur most commonly hematogenous route. Another is it can go contiguous from some local sites such as in areas of cellulitis, and another is the penetrating trauma such as iatrogenic joint replacement or internal fixation of fractures.
Considering this patient, what might be the foci for leading to this condition?
The artificial knee plate that the patient had installed for the fracture.
Yeah, 3 years ago. Very good. Okay. Right. Can you please tell me, yes, how this infection spreads via hematogenous pathway? Like, if you can tell me from where organism is carried out and in the bone, how does it spread?
in the hematogenous pathway, it affects the metaphyseal arteries at the
Very
growth
good.
plate, where these arteries are arranged in a looped pattern.
Yes.
So because of this special arrangement of blood vessels, there is turbulent flow in over here, and also the lining of the endothelium at this area, the cells have little phagocytic activity.
Yes.
So all of this contribute to it acting as a good vessel for microbial proliferation and infection.
Yes. Can you also please tell me how this blood vessels cascade is formed in the bones metaphysis? Yes.
This enters the afferent arterioles enter and loop around at the metaphyseal growth plate bone.
Very good.
Like the branches of the nutrient artery.
Yes. Then
along the.
All right. Okay. Very good. Can you please tell me how should this patient be managed now? What would you do next? What would be your next step?
So first, I would go for aspiration and send for culture and sensitivity, and I would also like to do an X-ray of the knee. And I would start with considering that my reports have come. I would then start with broad spectrum antibiotics that have both gram-positive and gram-negative coverage, like intravenous cephalosporins and flucloxacillin, along with gentamicin coverage. And I would I would give rest and elevation of the limb and splintage of the limb. I would suggest analgesia according to the World Health Organization analgesic ladder. And I would wait and see if the patient responds to the antibiotic therapy within 2 days. If I see that the patient is unresponsive, I would consider surgical drainage.
Yes.
I would go for saucerization and sequestrectomy if needed.
All right. Okay. Can you please explain why removal of the plate is essential?
Because it is acting as a foci for infection.
Very good. Okay. Can you please define the term pus?
Yes, ma'am. Pus is a collection of dead neutrophils and microorganisms.
Okay. Considering that it's osteomyelitis, what blood parameters would you consider or would you expect to be high?
I would find the because it is an infective condition, so there's going to be neutrophilic leukocytosis, and also the ESR could be raised.
Okay. CRP. Maybe?
And CRP, yes, ma'am.
Yes.
CRP also.
Okay.
Yes,
can you please define the term necrosis?
Necrosis is a form of cell injury which results in the death of a cell in a living organism due to either damage to the cell membrane or ion homeostasis in the living organism.
In case of pathogenesis of osteomyelitis, what is another word for necrosis?
Another word for necrosis, formation of the sequestrum.
Yeah, or involucrum. That is the last.
No, involucrum is the new bone formation.
So yes. Okay, yeah. Sequestrum, yes. Dead bone, yes. Okay, good. Right. Can you please tell me, you said pus will come out because of the raised intraosseous pressure. What is the normal level, normal pressure?
Normal intraosseous pressure. Sorry, ma'am. Can I get back to that later, ma'am?
Okay. Can you please please tell me? You've answered all the questions very nicely. Okay, what enzymes are released when the organisms invade and they are engulfed? So what are the enzymes that release the lyse?
Sorry, ma'am, I did not understand this question. Enzymes would be proteases, and mostly proteases would.
Okay, what are the bone layers from outside to inside?
There is the periosteum, then there is the compact bone, then is the spongy layer of the bone, and then there is the medulla.
Okay, what is the blood supply of the bone?
The bone mainly gets its supply from the artery, metaphyseal artery, and
Yes.
arteries from the surrounding structures, joints.
Okay, can you comment on the blood supply of the bone at the metaphysis or the epiphysis?
The blood supply of the bone enters through at the metaphyseal end, and it is looped. The arteries are looped in arrangement, and yes, ma'am.
I think there is like in epiphysis there is poor blood supply, so healing.
There is poor.
Yes, healing
Yes, ma'am.
impedes. It's not so quick.
Yes, ma'am.
Otherwise,
it's not quick.
Yeah.
The vascular entry is through the metaphysis.
Yes, that is it. But then towards the ends, bone healing or bone improvement is
epiphysis and the diaphysis.
Yeah,
Yes, ma'am.
yeah, good. This is what I was asking. Very good. Okay. Nice. Let us start. Yes, here is your question. Tell me once you've read this, there's little bit on the next slide. Right. So if you have read and understood, considering the critical care scenario, kindly tell me, how would you manage this patient now?
Ma'am, first I would like to start with airway breathing and circulation assessment.
Okay.
And considering her BP is low, I would start her on fluids and also take into like inside central venous line.
Yes.
And along with that, I would also get her USG and blood investigations, ABG, and and I'll do a physical examination to assess the patient even more, ma'am.
All right. Okay. What are the differential diagnoses that you consider for this patient? What's happening?
For either acute pancreatitis
Yes.
or acute cholecystitis or
Yes.
ascending cholangitis or pancreatic pseudocyst, ma'am.
All right. Can you tell me what might be the acute cause? What might be the cause of acute pancreatitis that you?
Ma'am, since her BMI is 40,
Yes.
I think it is due to obesity and
Yes.
probably gallstone pancreatitis, since in obese women, like gallstones are more common.
Anything else other than gallstones?
It can be alcohol induced, or it can be due to OCPs and other drugs like thiazide diuretics, or it can be due to trauma or iatrogenic.
Or okay,
yes,
can you please tell me
infections.
what is the pathogenesis behind acute pancreatitis?
There are two main pathogenesis, ma'am. One is due to duct obstruction, which causes reflux of bile into the pancreatic duct, which raises the intraductal pressure and causes damage to the acini. And the second one is due to direct acinar damage. It may be due to virus, bacteria, or trauma. And all of these lead to release of protease, lipase, and elastase, which causes further damage to the pancreas.
Yes. And that leads to hemorrhages.
And that leads to hemorrhages.
Yes. Very good. Okay, can you name few criteria with the help of which you can confirm your diagnosis?
Yes, ma'am. The most commonly used criteria are you have the Glasgow criteria for pancreatitis, you have the Ransom's criteria, the Balthasar CT scoring system, and Apache 2, which is used.
Very good.
Do you want me to elaborate?
Yes, kindly just tell me the Ransom's criteria on admission and after 48 hours, please.
Okay. Ma'am. On admission, if age is more than 55, if WBC count is more than 16,
Yes.
if the glucose level is more than 11 millimole per liter, AST more than 250 international units, and
Yes.
LDH more than 350. These 5 criteria. And
On
after
admission,
48
yes.
hours, you assess.
Yes.
Yes, ma'am. After 48 hours, you assess for hematocrit drop of more than 10%, rise in blood urea nitrogen more than 5 mg per dl, even after IV fluid hydration, base deficit of more than 4 millimole, fluid sequestration more than 6 liters, calcium less than 2 millimole per liter, and PK less than 8.
Very good. Considering the score that the patient gets, how would you think about the mortality, how it influences or how it depicts the mortality of the patient?
Ma'am, 0 to 1 is mortality is around 1%.
Yes.
Sorry, 0 to 2 is around 1%, 3 to 4 is 16%, 5 to
Yes.
6 is 40, and 7 and above is 100%.
100%. Very good. Okay. Can you tell me this patient has is tachypneic? Can you tell me
Yes,
why?
ma'am. It's either probably due to pain
Yes.
or pressure from the pancreatic pseudocyst, or it might even be due to ARDS.
ARDS. Okay, good. How do you think you should manage the pain of this patient?
According to the WHO pain ladder, ma'am,
Yes.
first I would go for non-opioids
Yes.
such as acetaminophen and ibuprofen.
Yes.
If it does not relieve pain, then I'll go for mild opioids like codeine. And even if that doesn't work, then I'll go for strong opioids and
Very
epidural
good. Very
anesthesia.
good. Okay. Can you tell me how can you diagnose if a patient presents with pseudocyst?
First, I would do a physical examination. I take the history, then do a
Yes.
physical examination.
Yes.
And if I have any findings in the physical examination, I'll go ahead with USG and probably MRCS.
What should be the particular or the typical history, typical finding in the history that you'll come across?
One is a previous attack of pain abdomen,
Very
at
good.
least 4 weeks previously,
Yes.
along with pressure symptoms.
Okay, very good. Can you please tell me the components of pseudocyst? Would you be
It's
able to?
usually the amylase-rich fluid, which
Yes.
is enclosed in a fibrous wall or a fibrous or granulation tissue surrounding it. Ma'am.
If you don't get to manage the patient with pseudocyst adequately on time, what are the complications that you should expect or you should watch out for?
One is rupture, either into the peritoneum or bowel. Second
Very
is
good.
infection,
Yes.
abscess formation, hemorrhage,
Yes.
and portal vein thrombosis, and that's
Yes.
about it. Ma'am.
All right. Good. Very good. Very good. Okay. Can you tell me how would the management of the patient with pseudocyst differ now? What extra would you do?
Usually, if it is the first episode, then I would only give symptomatic treatment, ma'am, because most
Okay.
of the, like 40%
It resolves
resolve on their
itself.
own.
Yes.
Yeah.
And
But if it is infected or more than 6 centimeter in size, and
yes.
if it is not going with symptomatic treatment, then I'd go ahead with gastrojejunostomy or cystojejunostomy or gastrostomy.
And biopsy of the wall to
And
rule out the
biopsy of the
malignancy.
wall.
Okay, good. All right. How would you take care of the nutrition of the patient during the episode of acute pancreatitis?
So there's been a recent change in trend with the management of nutrition, ma'am. They try to start off enteral feeding as soon as possible.
Yes.
So I would insert a NG tube and then start with enteral feeding depending on how the symptoms of the patient are.
Okay.
Or
yes.
If that is not possible, then I'd go ahead with PPN.
Very good. All right. Right. In this patient, serum amylase is raised. Do you think serum amylase is conclusive of acute pancreatitis? If not, then
No,
why?
ma'am. It is not conclusive since it is only elevated in the first 48 hours since the since the acute pancreatitis, and then it falls down.
Yes.
So it does not indicate the severity, or it is not specific for
Very good.
pancreatitis.
Then which enzyme is?
Serum lipase is more
Very good.
specific, ma'am.
Okay, can you name two situations in a patient with acute pancreatitis when serum amylase level is normal?
It can be either when the presentation, like when there is a delay in the presentation
Yes.
with the attack, and when the patient comes to you, and second
Yes.
is in chronic pancreatitis.
Very good.
In chronic pancreatitis, it's
What lifestyle changes would you advise to the patient to avoid future attacks of acute pancreatitis if he or
first,
she comes?
I would advise for lifestyle and beginning of exercise and try
Yes.
to reduce the weight, and avoid alcohol, avoid
Yes.
fatty food,
Yes.
and that's about it, ma'am.
Good. Very good. Good. Thank you.
Thank you, ma'am. Thank you so much.
Okay, started, and here is your question. Right, so if you have read and understood considering its surgical and optimization, kindly tell me what are you looking at? This picture A and B represents what? Which view? And
Ma'am, these are the foot bones
yes,
of the left foot.
yes,
The A is medial part and B is the lateral part.
very good. Okay, would you be able to identify certain structures for me? In picture A, what is 9, please?
9 is the tubercle of talus bone.
Very good. Okay, can you identify 13 over here? Picture A.
This is the calcaneus bone.
Okay. How many? All right. What is 21?
21. Ma'am, this is the navicular bone.
Tuberosity of the navicular.
Tuberosity. Yeah, navicular
Yes.
tuberosity.
All right. Okay. Can you please identify 10?
That's the medial cuneiform bone.
Okay. How many cuneiform bones are there?
We have 3 cuneiform, medial, cuneiform intermediate, and the lateral cuneiform.
Okay. Can you please identify here in picture B? What is this 19 showing you?
That is the Lar sinus.
Is there any other name of this that you know? And what's the significance of it? Why do we have that?
No, I don't know.
Okay. Right. Can you tell me how many arches there are in the foot?
There are 3 arches: medial
Okay.
longitudinal arch,
Yes.
lateral longitudinal arch, and the transverse arch.
All right. Can you tell me how these are each arches are formed?
Yeah, the longitudinal arch has some muscles, ligaments, and the bones.
Yes.
The bones include the calcaneus,
Yes.
the talus, navicular,
Yes.
the 3 cuneiform, and the 3 metatarsal bones. And the muscles include the tibialis anterior, posterior, peroneus longus, and also the flexor hallucis longus.
Very good. And the ligaments?
And the ligaments include the deltoid ligament and the short plantar ligament, long plantar ligament, and
Introitious
yeah,
and spring.
introitious.
Okay.
Yes.
Can you please tell me what are the stabilizing factors for the foot?
Stabilizing factors like
Yes.
the ligaments. On the medial side, it's deltoid, and on the
For
lateral
the
side, it's
foot, for the walking, okay.
ma'am, these muscles, arches,
Yes, and
ligaments,
yes.
and
Okay, can you please
yeah.
tell me what are the, all right, you just told me this, what are the ligaments or what are the ligaments which are attached on the medial and lateral aspect of the ankle?
Yeah, on the medial side, we have this deltoid ligament and also the spring ligament, short and long plantar ligament, and we have some parts of the deltoid ligament as well.
Okay, can you please
Uh,
identify this 6 over here?
Okay, ma'am, this is the deltoid ligament.
Yes. Okay, how deltoid
And
ligament is formed?
ma'am, deltoid
What are the
ligament has some
attachments?
attachments.
Yes.
Yeah, the proximal attachment is on the medial malleolus of the tibia, and the distal attachment it attached to the sustentaculum talli,
Yes.
to the spring ligament, to the navicular tuberosity, and
Yes.
to the neck and body of the talus bone.
Very good. Okay. If you can identify other marked structures as well in picture C, we can 26 and 18. Please.
Yes, ma'am. 26 is the navicular tuberosity,
Yes. Yes.
and
Very good.
18 is the spring ligament.
Yes. Yeah, very good. Moving on to picture D, please. If you can identify one.
Ma'am, one is the talofibrillar joint.
Yes. 3, please.
Sorry, joint ligament.
Ligament,
An anterior
yes.
fibular ligament, and 3 is the calcaneofibular ligament.
Very good. Moving on to E. If you can identify 3.
Ma'am, 3 is the same calcaneofibular
19.
ligament, and 19
19.
is the posterior talofibular ligament.
All right. Can you please tell me what you understand by the term mid-tarsal joint of Chopard?
Metatarsal joint of Chopard is the complex joint that is formed by the two joints that are lying transversely. Number one is the calcaneocuboid joint, and the other is the talocalcaneonavicular joint.
Okay. What type of joint is talonavicular? Or the
Talonavicular. Ma'am,
talocalcaneonavicular?
it is a ball and socket type of synovial joint.
Very good. And the calcaneocuboid joint?
Ma'am, that is the saddle type of joint.
Okay. Right. Can you please tell me what are the movements which are present at subtalar joint?
A subtalar joint, it performs the inversion and eversion of the foot.
Very good. Which muscles perform these functions, these actions?
Okay, so inversion is done by the tibialis anterior and tibialis posterior, whereas the eversion of the foot is done by the peroneus longus and brevis.
Okay. This ankle joint is most stable in which position and why?
Ma'am, in the dorsiflexion.
Why?
Because when we dorsiflex the wide anterior portion, they become fixed with the ankle mortise. And when we do the plantar flexion, the posterior part is narrow, so it doesn't fit. So it can be a wobbly and unstable.
Okay, can you please tell me which muscles they make up tendon Achilles?
Gastrocnemius, plantaris, and soleus muscle.
Very good. Okay, can you please tell me what type of joint is inferior talofibular joint?
Ma'am, it is syndesmotic.
Okay.
Type
Yes.
of joint.
Looking at this image,
Okay.
what is it? Can you please explain?
Ma'am, this is the foot, the gross right
Yes,
foot.
of the dorsum of the foot.
Yeah,
Okay,
dorsum.
yes. Would you be able to identify number 7?
Yeah, ma'am, this is extensor hallucis longus tendon.
Okay, 6, please. 6.
Extensor hallucis brevis.
Okay. Yes. Right. Can you please tell me how dorsal venous arches are formed?
Sorry, ma'am, can you repeat it?
Dorsal venous arch. How is it formed?
Yeah, ma'am, it is formed by the dorsalis pedis artery,
Yes.
as well as the lateral and the medial plantar arteries, which is present in the sole of the foot. So they will anastomose
Yes.
and form the deep arterial arch of the foot.
Or the cascade. Okay, can you please tell me the last question? Bell is gone, but we were asking very slowly. So can you please tell me the sensory nerve supply of the foot, of the dorsum of the foot, please?
Yeah, ma'am, the dorsum of the foot is supplied by the superficial peroneal except the first web space that is supplied by the deep peroneal nerve,
Yes.
and the lateral side of the foot is supplied by the sural nerve.
Yes.
And on the medial side,
Upper medial. Yes.
yeah,
by the
upper medial.
saphenous-
Yes,
by the
ma'am,
saphenous.
saphenous nerve.
Good.
Yes.
Good. That stabilization of walking, I was asking you if you could think now and tell me.
Stabilization of walking.
Yes.
Ma'am.
Once you walk, right? Then there are
Yes, ma'am.
phases of walking. There are stand phase and there is walking phase. So in what phase or what are the stabilizing factors which stabilizes your walk or the gait, if I can say?
Ma'am, these arches?
No, it's like
Ma'am,
acetabulum labrum, and then there is then there are ligaments like iliofemoral ligaments and others. So you'll read that. It's also given there. They
Okay,
just
ma'am, I will
stabilize
read
your
it.
gait.
Thank you.
Good,
Okay,
thank
ma'am.
you. Good.
Okay, ma'am, thank you.
Good. Thank you. Started your time and here is your question. It's depression, right?
Yes, ma'am.
Yes. Good. So if you have read and understood, considering it history-taking station, kindly begin.
All right, ma'am. Hello, I'm Dr. Aisha, one of the exam candidates today. How have you been feeling recently?
Not good, doctor. I've not been feeling good.
I'm sorry to hear that. In these past few days, have you been feeling a bit hopeless or down?
Yes, yeah, I have been feeling that, doctor, yes.
All right. And how long has this been going on for?
It's been a week, I guess, recently.
I see. Okay. Do you feel as if you no longer enjoy life or find little to no pleasure in it?
Exactly, doctor, yes, I have that thing.
And these days, have you been feeling overly tired or fatigued?
Yeah, I feel tired, like, without reason. Even if I'm doing nothing, like I feel
all right.
tired.
And how has your sleep cycle been recently?
Yeah, it has also not been good. I have difficulty, getting sleep, and then I often wake up, in my sleep.
Okay.
So it's difficult, doctor.
Okay. And if you wake up early, do you find that you have a difficulty to go back to sleep even though you're tired?
Yeah, sometimes, yes.
Okay.
Yes.
And as you've been having low mood, is there any particular time of the day that you feel that it's worse?
Usually towards the evening, I think.
Okay. And do you feel as if it gets worse throughout the day? Like it's better in the morning and gets worse during nighttime as the day
Yeah,
passes? Okay.
sometimes. Yeah, yes.
All right. And how are you eating? What is your diet like at the moment?
Not good, doctor. I like eating pasta,
Mhm.
Now that's my favorite, but I don't even feel like, looking at it now. I don't like, my appetite is really low.
I see. And have you noticed any change in your libido?
Yeah, yes, it has
Okay.
decreased,
Since this past 1 week?
Yeah, and even before, like when I had similar problem
Okay.
in the past.
Okay. Sorry to hear that. All right. Have you had any previous similar episodes like these where you felt really low?
Yeah, doctor, I just told you that I had maybe this is my third or fourth time, I think. I have been having similar kind of attack and all. So
Okay.
I don't know, like.
And all right. And have you ever been admitted for your mental health issues?
I think I was admitted on the first time, but then after that I didn't get admitted. But I was seeing my counselor,
Okay.
and I was in constant touch with my doctor.
All right. I see. And you've been also having counseling sessions for your mental health issues?
Yeah, yes, doctor. Yes, I have.
All right. And just a minute. Okay. Is there anything else that you'd like to tell me about?
Yeah, I don't know. Like, I have been having this for quite some time now, and I'm really worried now. I don't know if it's going to get worse, whether I'll be, okay anytime.
All right. Okay. I'll do what I can to help you out. Thank you.
Thank you, doctor.
Idea, concern, and expectation.
Oh, all right.
Yeah, you still have 1 minute, so please ask.
Okay.
Idea, he maybe
He already
told you, yes.
Yeah.
So expectation and concerns already mentioned in the yes. Any systemic review you want to ask?
All right. Have you noticed any headaches or any visual disturbance recently?
I have been having headache on off, but no visual disturbance as such.
Okay. And are you suffering from palpitations or chest pain?
No chest pain.
Okay. And have you had any problems recently with your urination, like burning or blood in the urine?
No.
Okay. Any tummy pain, diarrhea, or constipation, vomiting, anything like that?
No, not that I can recollect.
Okay. Have you been having generalized body aches and pains or joint pains or stiffness?
No.
All right.
Good. Can you summarize your history now, please?
All right, ma'am. So my patient is a 67-year-old gentleman who's been suffering from hypertension, diabetes, and hypercholesterolemia. He's here because of low mood for the past 1 week. He has had similar episodes in the previous 6 months, and he has also been, he has remained admitted for his mental health issues as well. He has the typical core features of depression, such as low mood, anhedonia, and feeling overly fatigued. And he has also been suffering from biological symptoms of depression. He's been he is unable to have proper sleep. His mood worsens throughout the day. He has been having low
So,
appetite and a
yes.
decrease in his libido.
How do you plan to manage this patient? What would be your next step?
Okay, the management plan depends on whether he's suffering from mild or moderate to severe depression. In case
Yes.
of mild depression, I would recommend him to go for regular exercise, have a proper sleeping schedule, and he should also go for cognitive behavioral therapy.
Yes.
In cases of moderate to severe depressions, medications have to be started. These include selective serotonin reuptake inhibitors, and some high intensity psychosocial intervention.
Yes.
Also, if I feel that the patient is an immediate or at high risk to themselves or to others, then they have to be admitted to a psychiatric ward.
Using which law?
Mental Health Act.
Yes.
Mental
right.
Health Act. Yes.
All right. Okay. Can you please tell me how would you differentiate, or how would you know, how would you categorize it if it's if patient is suffering from mild or the moderate or severe type of depression?
If the patient is suffering from all the core symptoms of depression and is also feeling suicidal, then that would suggest severe depression.
Okay. And what does this include? Mental Health Act, what does it include? Or what is it about, if you can tell me?
Ma'am, I'm not sure about this.
Okay. You'll read and you'll find out and tell us tomorrow.
All right, ma'am. Okay.
Good. Thank you.
Thank you, ma'am.
Yes, Dr. Kama, you want to give feedback for learning purpose?
Yes, ma'am. Thank you, Dr. Aisha. It was a nice presentation. You covered most of the things, especially the core symptoms and the biological symptoms, past psychiatric history also. Maybe like the influence we have in the scenario, we have that the patient is already admitted. We know all the history, and we just have to rule out the depression, right? But here, I think maybe since the patient presented in the A&E directly, I was just wondering, like, if you could do it as normal history, right, starting from the induction and everything, including the system, history, personal history, systemic review, and all. So that's the point of discussion. Mentioning about the severe depression, like you want to rule out suicidal tendency and all. So maybe if you're keeping depression as a provisional diagnosis, we could also keep bipolar disorder and or schizophrenia. So maybe for that we can also include few questions like whether he has a history of euphoria, hallucination, self-harm, or change in concentration, about cognition and all. These few questions, if we can include to rule out the differentials. Rest, I think you mentioned. So that this thing, like asking all the other histories, whether it is needed or not, that is a point of discussion now.
Good. Dr. Burhan wanted to give feedback. Right. So if you've read and understood, considering the clinical examination station, kindly begin.
Okay. Hello, I'm Dr. Flera. I'm one of the SHO working in this hospital. Could I confirm your name and age, please?
I'm Smith, 56 years old.
Hello, Smith. Nice to meet you. Today, when asked to examine your tummy, that will include looking, feeling, and doing some examinations of your tummy. Is that okay with you?
Yes.
Okay. Do you have a pain or any uncomfortable feeling right now
Yes.
in your tummy?
Yes, negligible, but you can continue.
Okay, I'll be very gentle, Smith. Okay. First, I'm going to start with the looking. It will be a general inspection. Okay.
Yes.
I'm going to look at the end of your bed.
Okay, what would you look for?
So I will see the general status, general nutritional status of the patient, and I will see the surroundings, any oxygen equipment there or not, anything. Then I will go, and after that I will start looking quickly on the patient's eyes and then the face, patient's tongue to see the dehydration status, and I will then start with the palpation, superficial palpation. So then I will tell the patient, okay, Smith, now I'm going to start with feeling of your tummy. I'll be able to feel any pain, please let me know. So I will start with the superficial palpation of his tummy, and then as the patient is having pain, so abdominal pain, I think the patient will generate some pain. So after having the pain, I will tell the examiner that, okay, the patient is having severe pain, and I think the patient is having also shortness of breath. So I am ill. So I would like to go according to the care for the critically ill surgical patient protocol.
Good. Okay, then.
Okay, then as the patient is talking with me, so I will consider that the airway is present, but the patient is having shortness of breath. So I will go for the non-rebreather mask with 15 liter per minute oxygen. So I will set the non-rebreather mask in the patient. Then I will go for the breathing of the patient. To see the breathing, I will give a general inspection. I will see if there is any central cyanosis or peripheral cyanosis or not. I will see if there is any patient is having confusion or having the use of accessory respiratory muscles. Then I will go for the palpation of the trachea. I will tell the patient, now I'm going to feel for the windpipe. Windpipe, it will be slightly uncomfortable. I'll be very gentle. So I'll be feeling for the windpipe or trachea. Then I will be going to I'll be going to see the patient's tongue to see the cyanosis. Then I'll be going to feel for the patient's chest expansion to see if it is equal on both sides. And then after feeling the chest expansibility,
how would you check the chest expansion?
I will see the chest expansibility by both finger. It will be in supraclavicular, clavicular, and infraclavicular region. Yes. And then I will in the front, I will see it in the anterior side and the lateral side. And I will also request for the back examination later. So okay. Okay, then after the chest expansion, I will go for the percussion of the chest. So I will see the percussion is resonant or dull or hyperresonant in both lung field. After seeing the percussion, I will go for the auscultation of the lung field, and I will see for the vocal resonance at the last. And I, at the same time, I'll also see for the pulse oximetry and saturation of the patient. After the breathing, and then I will go for see the circulation. To see the circulation, I will first see the capillary refill time of the patient, and then the JVP, or neck vein, the dehydration status, and the pulse. I will also offer to see the blood pressure of the patient. Then I will go for the auscultation of the 4 areas of the heart to see if there is any, or if there is any murmur or not. And I will also blood test to check the complete blood count, hemoglobin, and other blood investigations. And then I will go for the after completing the circulation, I will go for the disability. As the patient is alert, I will consider the patient as alert. And then I will, to see to do the, I will request if I can remove I'll remove the bandage of the patient's abdomen.
The examiner will
see
say consider. So you
okay.
don't have
Then
to,
I will.
Yes.
Okay. Then I will see the calf muscle. I will see the calf muscles if it is swollen or not on both calves.
Yes.
And then I will go for the the chart. If there is an early warning signs code chart, and there are also the other chart. If the patient is having any kind of missed dose of Clexane, or if the patient is having the TED stalking or not, and I will see the early warning signs code chart to see the patient is having any fever, tachycardia, or leukocytosis, or and also I will ask for the ECG report if the patient is having any kind of ECG changes. And
Good.
after that, I will thank the patient. I'll ask if I can help him with the dressing or not, and then
Yes, good. You just have 30 seconds, so you can begin summarizing your examination.
Okay, so today I have been asked to examine Mr. Smith, 56 years old, who is on his sixth postoperative day after thoracolectomy. On his history, he has complaint of shortness of breath with abdominal pain, which has led to on general inspection, his nutritional status was no. There is no central cyanosis. A patient has shortness of breath. As a patient was critically ill, so I considered the patient examining according to the care of the critically ill surgical patient protocol. As he was talking with me, I considered the ER's patient, but his saturation was low, 88% on room air. So but it improved later after I put on him rebreather mask, non-rebreather mask. And then on breathing, the patient has shortness of breath, but his was equal on both sides. Percussion nose was resonant, and on auscultation there was no added sound. And on circulation, the patient had no central cyanosis. His neck vein was his JVP was normal, and
yes, no signs of dehydration, normal heart
no
sounds.
signs
Yes,
of dehydration, and his bandage was not soaked on inspection of his bandage, and his cuffs not swollen.
So, what are your differential diagnosis?
Regarding the patient's history and examination, provisional diagnosis will be an anastomotic leakage.
Yes,
Abdominal pain due to anastomotic leakage, but also like to consider about phrenic collection.
yes.
Any kind of subphrenic collection that is causing his pain.
Yes. How would you confirm your diagnosis? What would be your plan of management?
Okay. After completing the examination, I would like to go for some investigations, like some blood investigation, and to see if to see the complete blood count, hemoglobin, and also renal function test and liver function test. Renal function is normal. I will go for the CT scan of the abdomen with contrast.
Yes.
To see and also to exclude if there is any chance of pulmonary embolism or not, I will also go for the CTPA.
All right, then what management would you do? How would you take care of the patient then?
Okay,
you put him nil by mouth, and then?
Yes, so I will make for the critically surgical care protocol.
Yes.
I'll give in nothing by mouth. I'll give IV fluid for resuscitation. Yes. I will put him on NG tube suction for the rest of the bowel. I will start IV antibiotic after doing the blood culture and talking with the microbiologist, and according to the hospital. I will also give the patient on analgesic, and then after considering the patient's status.
Maybe if patient does not improve, then you would have to do the laparotomy.
Then if there is an anastomotic leakage in the CT scan is shown, then we have to do exploratory laboratory.
Yes, good. Thank you.
Thank you, ma'am.
What's your question? Right. So if you have read and understood, considering that history taking station, kindly begin.
Okay. Hello, my name is Dr. Memuna and I'm one of the exam candidate today. May I confirm your name and age, please?
Hello, doctor. I'm Thomas. I'm 50 years old.
Nice to see you, Thomas. So, Mr. Thomas, I have been asked to take history regarding your medical condition. And for that reason, I have to ask few questions. Is that okay with you?
Yes, doctor.
Okay, thank you so much. So, do today.
Doctor, I'm having problems swallowing, and it's been happening for quite some time now, and I'm really worried it could be something bad. And also, I feel like I have lost some weight for the last few months, so it's just bothering me. That's why I've come to you.
Okay, I'm so sorry to hear that, Mr. Thomas. Can you please specifically tell me when you first started this problem?
So initially, it was about 10 months ago that I noticed that I'm having problem while I am swallowing any kind of food, usually hard food that I'm swallowing. But these days, even when I'm drinking water or some sort of juices, I'm just having problems. That's why I've come to you.
Okay, I'm so sorry to hear that. So is there anything which is making it difficult for you? Like the problem is like more aggravating?
Not that I noticed in like that.
Okay, you come, how you decrease your problem? Like, do you take more water, any medication for it?
I usually it comes and goes. So I usually wait for pass, and that's when it's very difficult. Otherwise, no, I don't do anything.
And do you vomit after eating food?
Sometimes, yes. I feel like something stuck in my throat, so I feel better if I'm just throwing up then.
Okay, and have you ever noticed blood in your vomitus?
No, doctor.
Okay, so you told me that you lost some weight. Did you like how much lost and in how much duration?
Yeah, I've noticed that all my clothes have got loose and have loosened up since last 2 months. So I think I've lost about 5 pounds or so in just last 2 months.
Okay, and what about your appetite? Is it
no appetite? I just have no appetite for food.
Okay, I'm so sorry to hear that. And Mr. Thomas, you told me that you are noticing something stuck in your neck, right?
No, doctor.
Okay. Did you notice any acid taste in the back of your mouth?
No.
And did you need changes in your voice?
No, not really.
Okay. And have you ever had a complaint of heartburn?
Yes. I've been having that for quite some time now.
Okay. So, do you have any, pain while swallowing?
Yes, doctor, I told you I'm having pain. I do feel pain. That's why I even drink water.
Okay.
It gets very painful.
Okay, so it's with the water or with the solid intake as well?
Before, at the start, it was with solid, but now with water, even with liquid food, I have problem.
Okay. So do you notice any changes in your, on the skin, like dry skin, dry mouth, something like that?
No, doctor. No,
okay.
doctor.
In the cold weather, did you notice any, tenderness, any pain in your tip of your fingers?
No, doctor.
Okay. And do you have any other problem like walking in your joints?
No, doctor.
Okay. This medical condition, do you visit your GP on regular basis?
I do take medications for hypertension, so I do visit for that.
Okay, can you name your medications?
I'm sorry, doctor, I can't remember at the moment.
Okay, it's fine, it's fine. And can you tell me, do you have any kind of allergies?
Not that I noticed.
Okay, what about your surgery? Like, did you had any previous surgery history?
No, doctor, I've always been fit,
Okay,
thankfully.
Okay, that's fine, that's good. So in your family, do you anyone have this kind of similar problem?
No, doctor.
Okay, if you don't mind, can I ask you some personal questions?
Of course, sure.
Okay, what you do for living?
I was a teacher, but I'm retired at the moment.
Okay, and do you smoke?
No, doctor.
What about alcohol intake?
I'm a social drinker.
Okay, to whom you live with at?
Can you summarize that now, please?
Okay, to complete, I would like to take the systemic inquiry. I will ask some question about the systemic inquiry, as I will ask the patient about the cause, the expectation, and the main concern of her. On the basis of 54-year-old men complain of progressive difficulty in the swallowing since 10 months. It initially started with the solid food, and now he having a pain while having a liquid intake as well. He also noticed 5 pounds of weight loss in the last 2 months, and the appetite is also decreased. The past surgical and medical history is significant. Yeah, he's been taking medication for that, and he's a non-smoker and a social drinker. So on the basis of the history, my provisional diagnosis is esophageal carcinoma.
Yes. Anything else?
And my other differential diagnosis is gastric carcinoma, maybe the gel pouch, and lung carcinoma, and eclasia, esophagitis, and neuromuscular disorders.
How would you confirm your diagnosis? What investigations would you ask?
Yes, ma'am. For the diagnosis, I will do some blood investigations in which I will check blood CP, LFTs, RFTs, and clotting profile. And I will do the chest X-ray, erect chest X-ray, and abdominal X-ray. Along with, I will also do barium swallow to check the barium swallow for the formation of any stricture or the anything structural changes. And I'll do the esophageal manometry for the GERD. Go for the endoscopy, and if there is any growth, I will do biopsy. I will take biopsy as well. And for the staging, I will go for the CT chest and abdomen.
Okay, what are the treatment options that you can offer?
Well, if the disease is resectable, we will go for the esophagectomy, and after radiotherapy. And if the carcinoma is non-resectable, then we will do the palliative surgeries like self-expanding metallic stent, and we will also go for the feeding jejunostomy for to start enteral feeding. And we also go with the chemotherapy and radiotherapy hours.
Okay, good. Thank you. Dr. Ulfa, do you want to give feedback? Yes. All right.
Hello?
Yes.
It's not.
It was good.
Thank you, ma'am.
Anything you want her to improve on?
It was good, Dr. Mamina. It was really good. I think you missed about You haven't asked whether I had any problem. That is an important thing. Like you asked hematemesis, you could have asked whether I had melena or any sudden notice and change of bowels. And that's about it. Otherwise, you were really good.
Yeah, she managed to cover everything. And the
Thank
ones
you.
she couldn't,
Yes.
she added at the end, so it was as good as being asked. Very good.
Yes.
Thank you.